angiofibroma. The MRI, maybe you will do it just to see the neural or intracranial involvement if you want to see. The CT can give you enough information. And then finally a DSA, the digital subtraction angiogram, is basically to look for or to embolize the tumor or to do balloon test occlusion. So in case during surgery, if you decide to do parent vessel sacrifice, then you should know that if you can do it successfully. So for that we will do balloon test occlusion and we'll show you that whether one carotid is enough for that patient. And obviously there is no wire roll-up biopsy in this case. So typically it starts from the pterygopalatine fossa. It will go laterally towards the infratemporal fossa. It will go superiorly into the inferior orbital fissure and then into the orbit. Inferiorly it can go to the maxillary sinus and in the chin. Once it starts moving little medially along the anatomical planes, it can extend from the spinopalatine foramen into the sphenoid sinus and then intracranially into the middle cranial fossa, and then further medially it can come into the nasopharynx and nasal cavity. So there are many classifications which are there. I find this Andrew Fish modified classification is the easier one to understand which tumor we are talking about. A very simple one, grade 1 is just tumor confined to nasopharynx. Grade 2 you will have involvement of the maxillary, ethmoid and sphenoid sinuses. Grade 3 will be infratemporal fossa, but there is no intracranial extension. Grade 3B will be intracranial extension, but it is an extradural, not intradural one. And 4A and 4B, 4A you will not have involvement of the sinuses, that is the cavernous sinus and the pituitary fossa, whereas 4B will have all those involvements. So these are just mimicking the tumors which can mimic like JNA. Maybe with the diagnostic guy can tell you details about how to differentiate. If you go to the history, these are the various treatment options which were available. Maybe hormonal therapy, radiotherapy still we are doing for the intracranial tumor where the blood supply is from the ICA and we are not embolizing in that part. Maybe gamma knife can do a better job. Surgical, all accesses and things, you know it better. Once we talk about the surgery, there is a quote in this Saviston's textbook of surgery. So a proper puncture technique wherein you can enter into the artery. So with the Seldinger technique, we started going into the femoral artery. And from femoral artery, we will go and sit into the external carotid artery just at the origin of the IMA. And from there, with a gel foam, you know ab gel. So that ab gel, we will scrape it, make a powder of that, and we will inject it into the tumor area. So we started doing that. But the limitations were that we were not entering into a particular branch, super selective branch. And the size of particles, the gel foam, we cannot control it because we are doing it manually. So it will vary from different size. So now over these years, there is so many devolution as far as the hardware is concerned, which is making the procedure more and more safe. Now what we have is a very fine microcatheter. So microcatheter, the diameter what we talk about, we used to talk about 2.7 French. From there, we have come down now to 1.9 French. So such a small catheter, we can enter into the whichever branch we want to go super selectively. Now once we go with such a thin microcatheter, the gel foam will not work because those particles will be too big for those fine catheters. It will get blocked. So what we have is PVA particles which are ranging right from 50 to 150 micron to up to 1000 micron. So based on the vascularity of the tumor, based on the catheter what we are using, we have all the options to use it. Beyond that, we have some liquid embolic material like onyx, which we can inject into the tumor. So there are many changes which has happened over these years to make the procedure more and more safe and avoid the non-targeted embolization. So when we are doing embolization, what our concern is that it should not go to some intracranial circulation, it should not go to some other area. So those things are being taken care of with all these hardwares, and again, it is easily available all over the country. So how you actually do it? So the first step we do is a femoral puncture. From there, a diagnostic catheter we put in, and the first step always is to do a ICA, that is internal carotid artery angiogram. What we are trying to look at is this choroid blush. You can see a ring here. So on internal carotid artery angiogram, once we see choroidal blush, I am almost safe and sure that embolizing the external carotid artery will not cause any vision loss to the patient. In case on this first angiogram, I don't see this choroid blush, I have to be careful that once I do a external carotid artery angiogram, and if I see a choroidal blush from that, then I know that this tumor embolization may lead to a vision loss. So this is the first and foremost step what we follow, and then we know that this is pretty sure. Now you will ask me, how frequently have you seen this? So in last 26 years, maybe I have seen it only once, that the choroidal blush is from the external carotid artery. So once this ICA run is done, we will go into the external carotid artery and identify which feeders are there which is supplying the tumor. And this internal maxillary artery, or there may be ascending pharyngeal artery, there could be facial or some other branches. Also we note that there is some blush from the internal carotid artery which we may not touch. I will tell you how we can tackle this also, but overall generally we don't touch these areas. Now once we have identified there is a blush from the internal maxillary artery, with that fine microcatheter we will go deep into the internal maxillary artery. So our microcatheter is right now deep into the internal maxillary artery. So there is almost no chance that your embolic material will come all the way back, all the way down, and then go into the ICA. So almost no possibility of stroke when you are embolizing this. Then again, after putting microcatheter here, this is a contrast we are injecting just to confirm that we are into the tumor bed. This is how the embolic material is prepared. This is a contrast, and then you select what size of PVA particle we want. Generally, it is 50 to 150 micron for all the JNS. And then we start embolizing the tumor. So how we do it? You can see here, we do it in pulses. You can see here, it is going in pulses. So we inject, let it go into the tumor bed, again inject a next pulse and let it go into the tumor bed. So once we start embolizing the tumor, the important is where to stop. So there are 3 stages. Initially we see, once we start injecting, the tumor is totally taking all the embolic material. The flow is very fast. Then once it starts significantly embolizing, the flow will become slow. So that pulse which is going into the tumor the speed will become slow. Then there will be stasis. Once I inject, I will see the contrast there for some time, and then slowly it is going into the tumor. And if beyond that I still keep injecting the embolic material, then I will start seeing the regurgitation. That is, the material will start flowing little back. So the idea is we will not go till regurgitation. Once we get the stasis, that's enough for embolization. Again, some over enthusiastically, if somebody does it more till regurgitation, no harm, because we are sitting deep into the internal maxillary artery. So this regurgitation will not happen all the way down and then into the IC. It is almost deep. So once that particular feeder is done, then we will go and search for other feeders. We'll see all these branches. If there is abnormal blush, we'll again enter into this particular, maybe the ascending pharyngeal, and we'll embolize that. Now once ipsilateral side is done, it's not over. We have to go to the opposite side, because like pelvic blood supply, you know that the facial supply could be from both the external carotid artery. So we check it from the opposite side. If there are feeders, again selectively enter into those feeders and embolize it, and then the job is done. And then this will be operated, the best results will be between 36 to 72 hours after embolization. It is not that I have embolized it and you immediately take patient for surgery, because what we are creating here is a sterile inflammation. So it is going to cause inflame and then it is going to shrink. So we have to give that much time for the tumor bed to get its vascularity to get reduced. Why not beyond 72 hours is good collateralization is there. So after 72 hours, maybe some other branches, the tumor will start taking the blood flow, and then you may expect a little more bleeding during the surgery. So typical window is 36 to 72 hours. So these are few, quickly we'll go through these few cases, which are the recent ones. A big, this is the post-embolization common carotid artery angiogram, and entire IM embolization. This is the post-operative picture, and the blood loss here you can see is little higher because of this residual. This is the post-embolization picture, but there is a residual flow from the internal carotid artery. This is another big tumor. Again, internal maxillary. This is the post-embolization picture, and in this case the blood loss was 850, and that's the post-operative picture, the after resection of the tumor. A very big tumor which is going into the orbit. I remember this case. Too many PVA particles were needed. In fact, we went totally out of our stock while embolizing this. This had a big supply from the internal carotid as well. This is the external carotid artery IMF feeders which were embolized, and the blood loss here was 1000 cc. Such a big tumor. Now what I was talking about modified embolization is, we can see here that there is a tumor flush here. So I have to go with my microcatheter right this way and take a complete U-turn and go in this direction, which may not be possible. So in those cases, we just put some coils here, because if I put embolic material from here, it will also embolize these branches, which we don't want to happen. So if you put a coil here, these branches will somehow get flow from the other collaterals. But after putting coil here, once I start putting embolic material, because of the coils, it will not go in this direction. It will only go to the area of interest and it will embolize this. So these are some modified techniques which we have to follow. In this case also, where we have put a coil here and the contrast goes in this direction. So how about when there is a intracranial extension, when there is a tumor supply from the internal carotid artery? So we talked about external carotid artery. Now internal carotid artery, those fine branches, if you try to enter, there is a very high possibility of stroke. So how to address those tumors? So on CT guidance, we can see the window, put a needle there into the tumor, put a contrast and confirm that your needle is in the tumor, and then with a liquid embolic material, we can embolize it completely. We have done few cases. This is how it is done. You can see on the tube. On CT, you can see this tumor area. The needles are under CT guidance are placed there. Inject contrast, confirm that you are there, and then you put a liquid embolic material like blue lipidol or onyx to embolize it. But with surgeon's experience, like we got a feedback from madam, that Radu madam, when we do it percutaneously, the operating for a surgeon becomes difficult, because the planes, they cannot get it very clearly. So nowadays we don't do this. We limit it only to the external carotid artery feeders, and we don't do percutaneous embolization. Now just to show you cases other than JNA for percutaneous, a single case, you know, the carotid body tumor, a very vascular tumor, difficult. There is not a single feeder. This is all, everything is getting. So here you just place a scalp pen needle, and through which we put a blue lipidol into it, and you can see this was the tumor. This is a post-embolization. The entire thing is gone, and that's the blue cast you can see. One more tumor, similar carotid body tumor. You put a scalp pen, embolize it, and you can see the tumor is embolized successfully. And then maybe if you decide to operate, you can operate it safely. Now everything is good about JNA of hemiplegia because of non-targeted embolization. So during the last few cases, I showed you how we can reduce this. A very rare case have been reported where there are abnormal communication between ECA and ICA. But you know, that is absolutely bad luck for us and for the patient, and it's not so common. But on ECA, if you see choroidal blush,